welcome Dr. Dominique.
Thank you so much, and good morning, everyone. It's a pleasure to be here, and I would like to thank everyone for the invitation. Actually, it's already my third participation in Saudi Spine Society. The last two were remote with online lectures, also in the Eurospine session, and I also participated in the Spine 20 in 2020, which was also here in Riyadh, and for obvious reasons we're also remote. I'm currently the Vice President of Eurospine, and I've changed institution in the meantime. When I was still participating remotely, I was still a spine surgeon in Oxford, where I worked for 10 years, and in 2022 I moved back to my native country, to Switzerland, where I'm chairing now the Spine Center at the University Hospital in Lausanne. So, with regard to this talk, which I've been teaching the technique of lateral ALIF for invasive since 2019, so this for my conflict of interest. So ALIF is, my story with ALIF began about 11, 12 years ago, when I needed a technique that allows me to reliably restore lumbar lordosis in one single segment, which is really nicely shown in this case here, where we have a significant pelvic incidence lumbar lordosis mismatch with opening of the adjacent disc because of the collapse of the L4-5 segment, then which was completely restored, and the normal alignment was restored here by a single level ALIF, which could restore the segmental lordosis. So the techniques available before that, the TLIF technique, PLIF technique, didn't really do that. And this really comes from the research that we did, and it was published in 2014-15, but obviously we had the results much earlier, and from there I realized that we need to have a technique with which we can reliably restore segmental lordosis. And like following on from the talk from Dr. Abdulaziz, he really showed these nice cases where a hypolordotic fusion had a catastrophic effect on the spine further down the line. And here we found that in the degenerative lumbar spine, if we have a mismatch of more than 10 degrees, we just increase the likelihood of a revision surgery of adjacent segment degeneration by about a factor of 10. And this was also shown then in biomechanics studies that we have much increased shear stress. So if we keep the pelvic incidence lumbar lordosis mismatch and do not correct that element of the deformity in the degenerative spine, then we have increased shear stress, which is the mechanism by which we predispose that adjacent segment and to failure, and the patient to a revision surgery. So ALIF at that point, and there was a publication by Christoph Siepe, who's the secretary of Eurospine in 2014, where they looked at a large series of ALIFs for the degenerative lumbar spine. So these are not deformities yet. And they found that they could get up to, on average, about 12 degrees of segmental lordosis if you do this wide release. So that also led me to think then, well, if I can get 12 degrees with a single ALIF, if I combine two, then potentially we are all of a sudden with two ALIFs in pedicle subtraction osteotomy territory, which about 10, 12 years ago for me was an interesting thought. And this led me then to treat patients like this in a very effective way with standalone fusions. This is a segment, these days we call this a latent deformity with a significant pelvic incidence lumbar lordosis mismatch of here 24 degrees. The patient has retroversion of the pelvis, so if we do here an in situ fusion, then we essentially predispose that patient to failure. A two-level ALIF could completely restore a physiological sagittal profile here with complete normalization of the spinopelvic parameters. ALIF also has been shown in the deformity cases to be a reliable technique to restore the sagittal profile. Here on the left, in the red bars, you see ALIF is superior to, for example, TLIF, whereas TLIF really shines in the posterior techniques. When we do TLIF, we can get better coronal correction, which is kind of makes sense because we do this release of the release of the posterior elements, which then mobilizes the spine and allows us to correct the spine in the coronal plane much more than in the sagittal plane with TLIF. This is an example also already quite a while ago with catastrophic failure after in situ fusion in a short lumbar segment, which then completely fell over the top. And here that was then done with multi-segmental ALIFs and posterior construct. So the advantages of ALIF is really that it allows us to complete the release of the anterior structures. So we can release the ALL, more importantly the anterior annulus. Indirectly, we can also release the lateral annulus, which very often ruptures if we've done a good release of the discs when we put in the trial. We can get in a good large cage with a good fusion footprint, and it is clearly superior in restoring segmental lordosis because we release the anterior elements very aggressively. And it also allows for an indirect and direct decompression. This is a case example here of a post-discectomy collapse. As a patient who's had several discectomies and then came with ongoing L5 nerve compression. You can see the vacuum sign in the disc indicating that there is some mobility in that segment still. And this then allowed me to open it up progressively and almost, similar to what we do in an ACDF, resect the posterior osteophyte, release the dura, take all the disc fragments out that were still in the canal, and restore the segmental lordosis and also the disc height for further indirect decompression. The disadvantages, one may consider vascular anatomy. This is sort of a relative contraindication. In Europe, we still can do our own approaches for those who've been trained in it. And some people prefer to still have an access surgeon. It is maybe not as much suited for ankylosed segments, although with the aggressive release, we can release the ankylosed segments quite reliably in some cases. But if they're very rigid, then we must combine this usually with posterior procedure, with grade 2, so-called ponte osteotomies, in order to maximize that lordotic correction. So the vascular injury, and this is a series in Nottingham published in 2012, we've seen there that the requirement for a vascular surgeon in a large center where people do anterior approaches routinely, the need for a vascular surgeon arises in about 3%. We also found that in patients over 60-year-olds where the vascular anatomy maybe is a bit different, they have osteophytes, they have adhesions, the vessels are a bit more fragile as opposed to the younger population, that we have a twice as high vascular injury rate in here, up to 13%. However, that did not result in an extensive blood loss of about a liter. But if we then say, okay, we do multi-segmental deformity correction from anterior, if we compare this to all the posterior osteotomies, then still a blood loss of about 1,000 milliliters or a liter is still compares quite favorably to all these posterior techniques. In addition, what I look for is the spine still mobile. If I see these vacuum signs, extensive vacuum signs in the disc, then I know that I probably can work quite well in the disc space and remobilize the segment and correct the segmental lordosis. What we must be aware of is, however, that there's always this anterior versus posterior factor. Why do we sometimes not get, you put in a 20-degree cage, but you don't get 20-degree lordosis? Well, that's probably because anteriorly we cannot restore the height necessary in order to fit the 20-degree cage into the disc space, because the posterior elements does not allow us to jack out the disc space enough in order to be able to fit that cage. So if that's the case, then we must do posterior osteotomies in addition, in order to get the full potential of ALIF and the anterior release. This is shown here in a case, in a revision case that had several surgeries for back pain about 20 years ago. She was at that point 46 years old, came with incapacitating back pain and could not stand upright anymore. She had to bend her knees quite extensively in order just to fit on the X-ray plate here. Then she also had a cauda equina syndrome due to an adjacent segment degeneration at the L3-4 level, and basically presented to my clinic in order for a revision surgery. At this point, this case is about 9 years ago, I still found revision PSOs and revision patients that have previous several surgeries, infection, decompression for cauda equina syndrome. I still found this a bit, if I can avoid it, if I can find a better strategy which avoids having me to release all this scar tissue, then I should try that. And so here I planned a 2-level ALIF with front back with posterior osteotomies in order to maximize the lordotic correction in each segment. So this gave me, at least on table, 21 degrees in one and 17 degrees in the previously fused segment. So the L5S1 was 0 degrees lordosis previously fused. However, in the standing X-ray, without supplemental posterior instrumentation and closing these osteotomies, that didn't really translate into an adequate correction. Only the posterior osteotomies then and the posterior fixation then gave us an adequate result in the sagittal plane. So all these ALIFs has been done in a supine position. And in about 2018, someone proposed to me, well, you know, gotta go. This is really an advantage doing these in a lateral position. And at that point, I thought, well, you're crazy. You know, you can't do all this vascular mobilization, all this release that we do in a lateral position. I don't even know how you would do that. And I'm going to show you now how that can be done. Lateral ALIF has a few advantages. It allows us to potentially do a single position surgery. So if you want to harness the power of ALIF but need to add a posterior instrumentation, if you can do this in a lateral position, then potentially you can do it in a single position surgery and do it all at the same time without having to reposition the patient. So it avoids that flip and that close to about an hour of repositioning, and thereby gives us a workflow enhancement. Some people say, and there's just one publication that suggested that there's a potential reduction in ileus reduce post-operatively. However, I must say in about 12 years of ALIF, I've not really seen, and I've not had a single patient that had a clinically symptomatic ileus. They all started eating almost normally the day after surgery. However, it has also some technically advantages. So for example, it avoids the midline release, or that we have to open the rectus sheath in the midline, thereby giving the patient a bit less pain. It potentially also decreases skin to spine depth in some patients, because essentially the bowel contents just kind of fall down, just like you would see with an XLIF. It is very simple to expose the retroperitoneum, and the lower rates of ileus, I'm not so sure that is an advantage. There is some learning curve, however, with the orientation, especially in placing the retractors. Sometimes I find it much more difficult to position, adequately rotate the cage. I find it more difficult to mobilize the vessels, and I will show you a case. Initially, also, the incisions are much smaller, so I usually cannot get my hand down there. So if I ever have a vascular injury, and I looked at strategies and rapidly increasing the incision in case there is a vascular injury, such that I can address it, because in most cases the incision is not big enough that I can fit my hand in there, for example, to compress the vein if it starts bleeding. This study here has shown that obviously, if you do single position surgery, you save time, because you don't have to reposition the patient, and in addition, you can work with an assistant, with a fellow, or with a second surgeon simultaneously. While you do the anterior approach, someone can start with doing a lateral approach, or can already start putting the screws, for example, if you have navigation, or these days a robotic arm. That study found that you can get about a similar amount of correction and lordosis. I find, even after having this now for a few years, I still not do as aggressive a release of the disc space as I would be able to do in a supine ALIF. The positioning here is like a standard XLIF positioning, which most of you would be familiar with, except what's important here is that lateral strap there needs to be in an oblique fashion, such that we have the abdomen free for the incision then for the lateral ALIF. The retractors are just positioned above table height, and the incision is normally along that black line is the line, the extension of the L5S1 disc space, and we try to do an incision just at the corner there of the rectus sheath. If the incision is too high, then we cannot get a horizontal angle in order to put the cage in, and the cages will always be rotated quite a bit. That's the ideal incision, really. It's just at the corner there, at the transition of the oblique fascia of the aponeurosis into the rectus sheath, and then we can push down the rectus a bit, and there's no need to split the linea alba, for example, which gives the patients a lot more pain than this small incision. Obviously, the incision is a cadaveric dissection. We wouldn't do such a large incision. It looks more like this, where you then place the retractors. They sometimes have a light source on it that allow us then to expose the disc space. And this is one of my first cases where I had a fellow holding a thoracoscope such that we can document how much you actually can see. The incision was rather small. There was you could not see very well from outside, but it still allows us good visualization of the disc space and release of the elements. This is a case, one of the first cases that I did then in a patient with an L5S1 post-discectomy degeneration with recurrence and nerve compression at that collapse. She also had back pain, and I indicated an ALIF in this patient. She was a young patient in her early 40s, and therefore I proposed to do it in a lateral position, and that's the intraoperative cage placement and postoperative standing X-ray, which allow to restore segmental lordosis and the disc height. As you can already appreciate, placing the cage perfectly in the midline, I find is still harder in the lateral position as opposed to the supine position. Here we can also do, as I mentioned, work simultaneously with two surgeons with a setup that allows us to access from the front, but also allows a second surgeon to work in the back in single position surgery, such as, for example, in this case here, where we did an L3 to S1 fusion, where we could put in a single position, could put in the cages and then the posterior screws. These were still done with C-arm. Now we would do them with navigation. In spinal deformity, the question is always, how do we treat the L5S1 segment? Because in my early days, I tried to be very clever, and I thought I knew which patients really need good anterior column support in L5S1, in which cases I could probably get away with an ALIF and just do S1 screws and not go to the pelvis. That didn't prove to be successful. I had to revise many of these cases, so these days I basically always do anterior column support at L5S1 and always go to the pelvis, these days in the S2AI fashion. If the L5S1 is part of the deformity correction, so if my planning reveals that I need to get more lordosis in L5S1, then I prefer to do an ALIF. If it is just a matter of anterior column support to enhance the fusion, then some cases do still a posterior TLIF cage, such as, for example, in rigid deformities, where I do a pedicle subtraction osteotomy. There I usually do not see the need to go anterior. Lateral ALIF in this case allowed me that it is basically almost possible if I do any lateral interbody fusion. I didn't have to worry about doing T-lifts anymore in the posterior stage, or even consider three positions. No, when we have the patient in the lateral position, we can put in the lateral cages and as well do an ALIF at L5S1. In the PSO, there's not as much of an advantage, as we still have to go then from anterior. This is one of the earlier deformity cases where I basically tried the technique here. The lateral ALIF would not really have been necessary, but it was more of a proof of principle, where we can place the cages and then do the posterior correction of this rather rigid scoliosis. This is a case where I planned multiple cages and actually had a second surgeon then at the same time put in the lateral cages. So we did an ALIF at L5S1 and XLIF cages, which I must say were not so nicely placed, but nevertheless XLIF cages at the same time, and then flip the patient to do posterior instrumentation. The limitations of lateral ALIF, as I mentioned, is really, to me, is in some cases the cage placement. I cannot place it always as perfectly as with a supine ALIF, and it's the vascular anatomy, especially if there's osteophytes like this. And this is one of my earlier cases where I then had to convert to a supine ALIF during the procedure, because I was not comfortable in mobilizing that big vein that was just over the disc space, which the MRI already suggests on the left side, in the lateral position. It means that you always work up, and you're sitting there and have to push the vein up, and that I felt not comfortable, especially was adherent, whereas in the supine ALIF I felt much more comfortable. I did a bigger approach and then mobilized the vein off the disc space. So in these cases now, if I see this type of vascular anatomy, especially with osteophytes in elderly patients, I stay away from lateral ALIF and either do it from posterior or do a standard supine ALIF if indicated. So in conclusion, ALIF is a powerful technique in selected patients. It allows the restoration of segmental lordosis in a quite reliable way. And especially with the lateral ALIF, we don't have a need for repositioning the patient if we also do lateral interbody fusions at the same time. It allows for a single position surgery and therefore enhances our workflow. What was appealing to me is that whenever I do in a degenerative scoliosis do lateral cages, I now always have the possibility to do also an ALIF in the same position without the need of additional repositioning. So before we move on, I would like to obviously attract your attention to the Eurospine annual meeting, which will take place in Vienna in 2024. We hope to see many of you there if you would like to hear more it's a very international meeting, as you know, for those who have attended. We have people from all over the world attending. It's not just a European meeting. And we would also like to invite you to submit your research to the Brain and Spine, which is the official journal of Eurospine and the European Association of Neurological Societies, the EANS, and we would welcome it's a open access online publication, and we would like to invite you to submit your papers. So with that, thank you very much for your attention, and thank you again for the invitation.